be about rational antimicrobial use. So this is very timely because a lot of antibiotics now are becoming um, uh, resistant, no? Because we have antibiotic misuse. So we use antibiotics left and right, sometimes even for viral infections or for unknown indications, and therefore there's a rapid increase in multi-drug resistant infections, no? So right now, you may have known, you may encounter patients who have UTI and pneumonia that are drug resistant. Maybe you have seen patients with UTI uh, um, with a sensitivity only to antibiotics that are IV, so they have to be admitted, or pneumonia that are extremely drug resistant. And we also see patients with multiple drug resistant tuberculosis and extremely drug resistant tuberculosis. So this is because of improper use of antibiotics. So remember that antibiotics are not candy. Okay? These are very potent drugs. They are life-saving, but at the same time, if used inappropriately, there can also be side effects. As an example, the effects of overuse of antibiotics on in the pregnant woman, especially also in the fetus and in the infant. So, uh, injudicious use of antibiotic in infants can alter the gut flora of the infant, and it is linked to asthma and allergic diseases in the baby. So if the pregnant woman has been given a lot of antibiotics, there has been linked to development of asthma and allergy and atopy in her baby when the baby is born. And babies who are given massive doses of antibiotics because of infection and then they're admitted in the NICU are also more prone to obesity later on because their gut flora has been altered. So it's important to remember that so we don't just prescribe antibiotics left and right. Okay. So there have been, what are the causes of antibiotic resistance? Okay. So it happens when the bacteria change and become resistant to the antibiotics used to treat the infections they cause. So the most common causes of antibiotic resistance, of course, is the overprescribing of antibiotics. Sometimes, di ba sipon lang, viral naman, and then we prescribe antibiotics because either we don't have the laboratory test to confirm if this is viral or bacterial, or the patient really wants us to prescribe something. Some patients always expect a drug instead of just telling them to drink fluids, to hydrate, to rest, etc. Or it can be, this is also common, patients do not finish their treatment. So once they feel better, after 2 days of antibiotic for UTI, they do not finish the treatment. So the bacteria is still there, weakened, and then later can come back and is already resistant. There's also overuse of antibiotics in livestock and fish farming. So because of factory farming, especially pigs, they are really loaded with antibiotics. They're given antibiotics every day in their food, and therefore we ingest that and it accumulates in our body, and therefore we also develop infections that are already resistant to the usual antibiotics. Also, if we get bacteria from the meat that we eat, then most likely these bacteria are already resistant to the common antibiotics because the pig or the cow has already been given antibiotics in the food. And there's one study wherein cows are given in Belgium, wherein cows are usually given 37 doses of antibiotics in their lifetime. Another cause is poor infection control in hospitals and clinics. So in hospitals, sometimes there's no infection control committee that will police the use of antibiotics among doctors. For example, some doctors even give third generation cephalosporins as preoperative antibiotic prophylaxis, which is not correct. But if there's no way to monitor, sometimes this can happen. Or sometimes, how are the antibiotics disposed? The unused antibiotics, do we throw them in the sink? Because if we throw the uh, unused, yung unfinished antibiotic in the sink, then there can be bacteria that can grow in the pipes in the sink that are already very drug resistant. Lack of hygiene and poor sanitation, of course. So if in the community, the trash is thrown everywhere, or in the hospital premises, there's poor sanitation, then there's the development of bacteria, which can also be very drug resistant. And very importantly is there's lack of new antibiotics being developed. So the pace of the development of multi-drug resistant antibiotics is very fast. However, the pace in the development of new drugs is not fast. There are now many drugs, strains of tuberculosis that are very drug resistant, but we don't have a lot of anti-TB drugs being developed. So that is a real problem. That's why the WHO and DOH are trying to do something about it. And I hope that we all cooperate in this respect. So, for rational antimicrobial use, every time that you will prescribe an antibiotic, please think of the indication. Is there an indication for this antibiotic? What for? No, for what illness? Why? Why are you giving it? And what are you treating? And then do the diagnostic workups, no? Hindi yung bigay lang tayo ng bigay. We also have to check, is this really a bacterial infection? And try to identify the etiologic agent. So if possible, do culture. I know that it's hard in some hospitals where not even culture. I know that in some government hospitals, cultures are not available, but ideally, we really have to do cultures, no? Especially for serious infection. And then we have to do the correct type, dose, route, and the duration of antibiotic. We have to know the precautions. Ano ba yung drug-to-drug interactions, no? What are the things that we have to watch out for? For example, clindamycin, it can lead to Clostridium difficile, which can lead to very severe diarrhea and sometimes dehydration and death, no? So all those things. And of course, the cost. Can the patient afford to buy 1 week worth of this expensive cefuroxime, for example, no, after a normal delivery? So lahat yon we have to think about it. Because if they cannot afford it,
Wait
then
lang, wait lang.
we have to change, no? We have to modify the antibiotic that we prescribe. So this came from the manual, no, from the guideline of another hospital, but this is very universal, no? It can apply to all our hospitals, no? So before starting the antibiotic, every effort should be made to collect the specimen. That's why, remember, I always tell you, before you start, for example, antibiotic for septic abortion, get the specimen first for blood CS or for urine culture, because otherwise once you start um, the very strong high dose antibiotic, you have to get all the specimens. And then once the etiology of the infection has been identified, the choice of antibiotic is determined by the sensitivity. So usually after 2 days or 3 days, then the culture result is available, then we can modify the antibiotic so that from a broad spectrum, high dose IV antibiotic, we can focus using a narrower spectrum antibiotic. Timing, regimen, dose, route of administration, and duration of antibiotic therapy is regularly reviewed and optimized. So we don't have to always complete 7 days or 14 days of IV antibiotic, di ba? Sometimes we have patients with surgical site infection. Initially, talagang pangit, no? Open na open. Yung, kunyari, CS na surgical site infection. But usually, after 2 days or 3 days, If the wound looks good, there's good granulation, no fever, improving WBC count, sometimes you can even discontinue the IV antibiotic, or we can shift it to a more narrow spectrum oral antibiotic. And remember that all antibiotics should be assessed by the prescribing physician within 48 hours from time of initiation to determine confirmation of infection and the need to de-escalate or streamline. So parati yung i-reassess, ha? Hindi yung porket nag-prescribe tayo, sometimes since like for example in our government hospital, since free naman, di ba? Sige, 7 days of IV ano ba, imipenem, di ba? Ganon. So, nangyayari, nagkakaroon na tayo ng carbapenem resistance. And what will we give? Okay? And remember, antimicrobials, if the oral option is possible, then give oral rather than IV. So for example, metronidazole, actually, the bioavailability of oral metronidazole is better than IV metronidazole. So if the patient is able to tolerate oral feeding, able to tolerate yung hindi siya nagkaka-gastrointestinal upset with oral metronidazole, then give oral metronidazole. Okay? And when choosing antimicrobials, the history of antibiotic use within the previous 3 months should be considered. So you have to ask, did you take an antibiotic in the past 3 months? If yes, then this antibiotic that you should be prescribed should be from another drug class, another kind of antibiotic. And always remember to ask for a history of allergy, because this is important, because there have been cases also of anaphylaxis, no, due to antibiotics. So not all antibiotics are life-saving, no. Sometimes if a patient develops a life-threatening allergy, it can actually cause death. And etong question ko, sige, may tatanungin ako. Sino bang tatanungin ko? Sige, tatanong ko si sumagot. Routine ba ang skin test prior to IV antibiotic? Should it be routine? Is it part of the SOP, for example, by the CDC and the WHO to do skin test before giving an IV antibiotic? Dr. Babar, can you answer?
Ma'am, the answer will be no po. It's not routine.
Intersection kaliwa tayo.
No. So, hindi na siya SOP because there are a lot of cases na nagpo-false negative sa skin test. But for medical legal purposes, a lot of hospitals in the Philippines still do skin test for medical legal purposes, no? Ang mas important lang is to ask for the history of allergy. Okay? Okay, and then when you are going to prescribe an antibiotic, on the left-hand side of the chart, in other hospitals, this is what they do. They write the diagnosis and then write the indication for giving the antibiotic. And then the pharmacist will not give the antibiotic if there's no indication. So ganun siya. So hindi tayo pwedeng magbigay lang ng antibiotic just because we feel like it, ganun. Talagang dapat meron purpose for giving it. And after, ayun, na-mention ko na, after 48 to 72 hours of antibiotic, re-evaluate. Example, mga septic abortion or endometritis. And then, you already did DNC. Maganda na siya, no? No more fever, no more pain. So, anong gagawin mo? Sige, sinong tatanungin ko ngayon? Dr. Ilagan. Sino ba to? Dr. Ilagan, what will you do? For example, meron kang endometritis, you gave IV clindamycin, gentamicin. And then, after 48 hours, no more fever, no more pain, no more foul-smelling vaginal discharge. What will you do?
We may discontinue the antibiotics na po.
Correct, no? So, stop the antibiotic. Pwede mo nang i-stop yon. So, usually for endometritis, Basta 48 hours na asymptomatic, you can already stop the antibiotic. Okay? But of course, case-to-case basis yan, ha? Yan. Alright, so before surgery, remember, pag sinabi mong antibiotic prophylaxis, it means that the patient doesn't have any infection. So yung antibiotic prophylaxis should be given within 1 hour before surgery, hindi 2 hours before surgery. Kaya minsan, di ba, nadidelay ang operation. Kaya magandang timing is to give the antibiotic upon induction of the anesthesia. Okay? Ayan. And then, pagka sinabi mong prophylaxis, yung antibiotic, you can continue with post-op, but for only a maximum of 24 hours post-op and then stop. Yan. So, hindi natin nasusunod yan, di ba? So, try to follow that. Because if you are very sure about your surgical technique, wala ka naman naging complication like bowel injury, bladder injury, hindi naman massive ang blood loss, actually, we don't need to give oral antibiotic. For normal spontaneous delivery, yun. And then wala namang episiotomy, no episiorophy, we don't need to give antibiotic. Okay, it's not routine. I'm not saying na don't give, pero it's not routine. If there's an episiotomy, then probably antibiotic may be necessary, especially if the episiotomy has been quite big. For abortion, there's not enough, actually, this is a gray area. Usually, we would give one dose, no? Kahit one dose lang ng IV antibiotic. Okay? What about intrauterine fetal demise? Do we have to give antibiotic for all cases of intrauterine fetal demise? No. So if the IUFD is not because of infection, don't give antibiotic, no? Kasi marami namang cases of intrauterine fetal demise that are not septic, di ba? For example, the baby has a congenital anomaly. Why would we give antibiotic, di ba? Only if really we suspect an infection. So this is a policy of East Avenue Medical Center, but I'm not sure if this is already being followed. Actually, we should do this, no? Because this is already a policy by the DOH. So, ginugroup na kasi yung mga antibiotic. There's group A and then there's group B. For group A, restricted antibiotic, amphotericin, colistin, linezolid, micafungin, vancomycin, voriconazole. These are really very restricted antibiotics. We try to limit their use because ito na yung pinaka top of the line natin, hindi tayo dapat magka-resistance. So before prescribing it, we should refer to the ID service for management. Yung group B naman, these are restricted but not as restricted. Yung ertapenem, meropenem, cefepime, we can give it, no? Even without referral to the infectious disease consultant, but within 24 hours, then the infectious disease consultant should give a go signal if we should continue this antibiotic. So for group A, yung highly restricted antibiotics, it's mandatory referral to the ID consultant and then may issue 24 hours worth of antibiotic pending orders of the ID consultant. And then after that, kailangan isulat na talaga ng ID consultant and resident in the chart if the antibiotic is approved, no, for continuation or not. Yan. And then the pharmacy will receive the form and then it will depend either the same antibiotic is continued or the antibiotic is ordered to be shifted to another drug or discontinued kasi hindi na approved. For group B restricted antibiotic, ito yung mga carbapenem, mga imipenem, meropenem, vancomycin, no? So we also have to refer to the antimicrobial team and then we give 24 hours worth of antibiotic but also pending the order of the ID consultant. Okay, so parang same din, ano? All right. Remember that antibiotics shall be started only if there is a clear clinical justification. So antibiotics are life-saving. We know that, no? Before, we used to die of appendicitis, we used to die of mga simple infections, cellulitis, but now because of antibiotic, we don't die of these diseases. But remember that antibiotics can also lead to rashes, dizziness, nausea. Very common are yeast infections, diarrhea, and Clostridium difficile infection, no? Which can lead to colon damage and death. So, 1 out of 5 medication-related visits to the emergency department are due to reactions to antibiotics. So what can we do? Minsan we have patients with cough, no? Productive cough. We don't know if it's viral or bacterial. So syempre, aside from the COVID test, if it's available, we can request for procalcitonin, no? Kunyari, mukhang pneumonia, we don't know what it is. Because if it's bacterial pneumonia, then usually the levels are high. If it's viral, then the levels are low. So we can be guided. Okay. So narrow spectrum antibiotics are preferred. So usually, pag septic naman kasi talaga yung patient, most of the time in East Avenue Medical Center, patients come to us talagang septic na, they're parang you don't know if they're going to live or to die, then we don't have a choice but really have a shotgun approach, no? Give the broad spectrum, very strong antibiotic at the start because we don't have the culture result yet. Yes, it is warranted, but these are the only indications for giving broad spectrum like life-threatening infection, severe sepsis, significantly immunocompromised, confirmed or suspected polymicrobial infection, previous therapy using narrow-spectrum antibiotic failed, or there's a risk of infection with resistant pathogens. But for mga other conditions like mga UTI na hindi naman severe masyado, of course, why should we give those broad-spectrum antibiotics? So remember lang to use it judiciously. Okay. So review lang, so we know what antibiotic to give. So these are the common antibiotic regimens. If we're thinking preoperative prophylaxis, it means na the patient doesn't have a pre-existing or existing infection. For cesarean section, the best antibiotic is still cefazolin. Cefazolin because the half-life is very long, kaya siya maganda, and it's broad spectrum. So we give 2 grams or 3 grams. So yung 3 grams, we give it if the patient is 120 kilograms or more yung weight. Now, if the patient is already in labor, kunyari you have to do CS and then in labor, active labor ang patient with ruptured bag, aside from the cefazolin, then we can add azithromycin, 500 milligrams IV single dose in order to prevent surgical site infection. Because we have a lot of patients who have undetected, no, chlamydia or yung mga ureaplasma urelyticum. So, they can lead to surgical site infection. So, give azithromycin. Mga patients natin for total hysterectomy, mga explore lab, cefazolin is still good, or we can give cefoxitin, or we can give clindamycin, gentamicin, no? If your patient has a kidney problem, it's better to give, di ba, gentamicin single dose, no? I mean, 1 grams once a day because it's less toxic to the kidneys. So, you also have to consider yung mga kidney function, renal function ng mga patient. For normal spontaneous delivery, actually, if it's only spontaneous delivery without any episiotomy, actually, it's not routine, no, to give antibiotics. No? Only if there's an episiotomy or the patient really had a prolonged labor, prolonged ruptured bag, then probably we need to give antibiotic. For abortion, okay, some would even say don't give antibiotic if this is a non-septic, no? But maybe in the case of in our case, at least we give a single dose of IV antibiotic, no? Cefazolin, cefoxitin, or ampisulbactam. And the ACOG, actually, ang recommendation nila is to give doxycycline 200 milligrams per RM single dose. Okay? But I haven't tried this yet. Mga cases of laparoscopy, hysteroscopy, hysterosalpingogram, CISH, endometrial biopsy, cervical punch biopsy, antibiotics are not routinely recommended. Okay? So, hindi naman lahat kailangang i-antibiotic, especially for yung mga cervical punch biopsy, endometrial biopsy. Usually, we don't give antibiotics. But for these conditions, yung mga, lalo na yung SIR, hysterosalpingogram, hysteroscopy, remember that you will be inserting an instrument from the vagina going inside the uterus, and then you will be some especially yung mga CISH, hysterosalpingogram, you will be insufflating fluid, no, inside the uterus. And if you did not screen the patient for mga STD, especially for chlamydia, you might actually push the patient to developing PID after the procedure. So even though it's not routinely recommended, it's still better um, to cover for chlamydia infection, no? To prevent PID after the procedure. Okay? Remember that, very important. Na before doing SIR, hysterosalpingogram, hysteroscopy, please give antibiotic against chlamydia. Especially, we don't routinely uh, screen patients for chlamydia. Okay? So also check the cervix well if the patient has an infection before doing these invasive procedures. Because most of the time, these patients come to you for infertility. And then if you cause PID later on, you'll be actually worsening her problem of infertility. So, especially if the patient had a history of PID, or on ultrasound, there's already hydrosalpinx or history of blocked fallopian tubes, then be very careful, no? You have to give antibiotic first. Now, meron naman tayong patients who don't have infection but they are high risk for developing infection, surgical site infection, endometritis. For example, mga patient mo na, di ba, they went into labor, prolonged labor, and then ruptured bagnan, and then multiple IEs, 5 IEs or more, eventually nagdystocia or PROM, and then you had to do a cesarean section. You know that this is really high risk for surgical site infection, right? So, I would suggest you can already, before the CS, no, give na Clindagenta plus azithromycin. Now, for septic abortion, merong mga different, a lot of regimens, but one of the good ones, no, are ampicillin, metronidazole plus gentamicin. Or we can give ampicillin plus gentamicin plus clindamycin. Okay? So, antimicrobial stewardship, just remember, right drug at the right time, right dose, right route, right documentation. So you have to document it in the chart, the right reason, and the right response. So if the patient develops allergy or adverse event following antibiotic, we should give the right response. Okay, so thank you very much. So hopefully this will help you, no, para magita yung good doctors so we can stop antibiotic resistance. Thank you. Do you have any questions?